Hi everyone, this is Tim, your lecture instructor for the transition of paramedic to RN program, and this module is going to be based on hematology. I know that this week there's a lot of reading, there's a lot of comprehension, a lot of things to memorize and understand. I want to try to break this down for you as probably as easy as possible. I will tell you that chapter 32 is more of a good to know refresher chapter. Definitely read it, but you don't have to necessarily memorize it. Just do more of an understanding and kind of bringing forth a lot of information that you probably once understood and knew, and now it's just kind of refreshing and reminding you of things. So I will point out that chapter 15, I think for me is probably more important for you guys to learn, just because they have a lot of good information for whether it be cancer patients or patients who are doing chemo, or even in general, patients who have chronic diseases that we can't cure. A lot of times we really are doing more of treating symptoms as opposed to anything else. So, and I think that chapter 15 does a pretty good job about doing that. So definitely pay attention to the interventions, the rationales. I do know that the plan of nursing care boxes and stuff, I think they're pretty good ideas and stuff. So again, pay attention more to those and the rest of the chapters. Definitely read them and understand them. Definitely the disease processes, but again, this is all about more interventions than anything else. So, as I mentioned to you guys before, I'm not a molecular chemical composition type person. What I do want you to understand is more of the platelets, the erythrocytes, the neutrophils, the eosinophils, basophils, macrophages, the T lymphocytes, and the B lymphocytes. This module is all about what to do when your patient's low and what to do when they're high, and the reasons why. So again, don't spend too much time on chemical, and molecular structures. Just do more of interventions, and like I said, what you're trying to do when your patient either has too much or not enough. So the bone marrow is actually what produces the red blood cells, white blood cells, and the platelets. With the white blood cells, you have the lymphocytes, the monocytes, the eosinophils, basophils, and neutrophils. And once you actually take a sample of blood and actually spin it and break it down, you actually have plasma, which is 55% of what you have drawn, and then the rest of it's 45. And that 45% is the platelets, the leukocytes, and the erythrocytes. And everything else is more of just the, albumin and the fibrinogen, gases, other substances and stuff. So again, it's just more of you understanding as far as what's really consistent in your blood. Here's a really good picture. I know it's kind of corny and cheesy, but I think it really makes a lot of sense and just very quick and easy and simple. So with your erythrocytes, it's full of oxygen and it's mostly red blood cells. So I think of being, the oxygen carrier. And with the leukocytes, this is more of, whatever your body can do to actually help prevent either from disease or once you actually get some sort of type of disease, what your body will do to actually fix it. And then the platelets is premature clotting factor. So, think of it as being, wherever you're bleeding, your platelets should be able to help keeping you from bleeding to death. And just think of just scabs. So here's your white blood cell counts. You've got the neutrophils, which is for your immune defenses, eosinophils, which is defends you against parasites, basophils is the inflammatory response, monocytes are the immune surveillance, and B lymphocytes is the antibodies, and T lymphocytes is the cellular immune response. So again, it's really just kind of understanding what each one of the blood cell type does and what the function. So for the red blood cell, it's your body's way of actually carrying and transporting oxygen throughout the body. When it's actually low, your kidneys will actually send out a signal saying, hey, you know what, we don't have enough, and usually it's erythropoietin. That will actually tell your body to start making more, so that way you're able to carry more, which then will pick up oxygen and transport it throughout the rest of the body. For platelets, again, think of it as being more of a scab, and it can be either internal or external. So if you have some sort of, either vascular problem, especially for, as we mentioned in the cardiac modules, that, when you have stress and cigarette smoking and caffeine and things that will actually cause your blood pressure to go up and down, it'll cause the veins and the arteries to contract and relax. And with that actually causes some damage. So when you do have those little slight tears, your platelet's job is to really actually repair them. You have a patient who has either an incision or some sort of wound, and the idea for the body is for it to actually cause the platelets to respond to that and actually form some sort of healing mechanism so that way you don't bleed to death. Hematological studies, we actually have CBCs, which is the blood cells, and the hemoglobin and hematocrit. We have PT, which is prothrombin time. We have INR, which is the international ratio time, and APTT, which is the activated partial thrombin time. So the ones that are in the yellow are the ones that determine your clotting ability. So if you're actually very low on platelets, you're going to bleed, and if they're very high, then you actually start developing blood clots. So the way to think about this too is they will, whether it be for surgery or whether your patient's on some sort of medication that will thin the blood, they'll actually do testing to find out how thin it is or how thick it is to determine whether or not, if your blood's too thin and you go to surgery, then you won't have the ability to actually clot and you'll actually bleed to death. Or if you have, let's say, AFib, which actually causes blood clots and stuff, you'll take something called warfarin or Coumadin, and that will allow you to thin out your blood, and that's good because you don't want those clots to form and then spread throughout the body. So anyways, so these three are really taken regularly for those who either have clotting factor problems, whether it be too thin or too thick. So for anemia, this is lower than normal hemoglobin and fewer than normal circulating erythrocytes and a sign of underlying disorder. So hyperproliferative, it's a defect in production of red blood cells. It's caused by iron, vitamin B12, or folate deficiency. It's decreased erythropoietin production and such things as cancer. Hemolytic, which is the excess destruction of red blood cells. So anemia itself is really that you don't have enough red blood cells. And if you don't have enough, then you don't have enough of a product that will actually help transport oxygen throughout the rest of the body. So again, what are you going to do about it? So you either can fix the underlying cause, or you can actually, give transfusions of packed red blood cells. It could be diet related. There's several different reasons why, but again, it's really just figuring out what it is and fixing it. So far as assessment of a patient that has low red blood cells, they'll often find fatigue, weakness, or malaise. You have pallor or jaundice. You have cardiac or respiratory symptoms, tongue changes, nail changes, angular chelosis, and pica. So to break this down real quick, if your body is lacking red blood cells, which is the carrier of oxygen, that means you're going to be low on oxygen, and at that point you're actually going to start having these symptoms. So lack of oxygen, you're going to start feeling very tired, you're going to have some probably slight dizziness, you're going to feel very weak. There's not enough oxygen going to the major parts of your body, whether it be organs, whether it be muscles, so forth and so on. So think of people who don't have enough oxygen due to the fact that they don't have anything that carries it. That's when you're going to start having the issues. For cardiac and respiratory symptoms, again, you really need the oxygen to be able to, make your body function. And without the oxygen, your respiratory rate is probably going to go up in order to compensate, and your heart's probably going to start speeding up just to be able to take what you do have and make it as efficient as possible and circulate it throughout the body. With tongue and nail changes, I think that your cap refill will be greater than 3 because you're squeezing the fingers to be able to determine whether or not the capillary refill is good or not. And because of the fact that you're lacking the oxygen in the packed red blood cells, you're starting to shunt that what you do have to more of the center core of the body. So, and then with pica, from what I've been told, I'm actually quite sure if it's been proven, but those who are anemic will tend to chew a lot of ice and they'll crave a lot of things that, for whatever reason, again, is a symptom of anemia. So here's your assessment findings. So if you actually look under the conjunctiva or under the tongue or the hands, you'll find that they're actually very pale, as opposed to when people have enough, they tend to be very nice and bright and pink. So so when you're actually doing your assessment, you can check these 3 areas, and they'll tend to kind of give you a little bit of an idea of whether or not they're anemic. Here's another example of anemia. So again, you'll have the fatigue, you'll have the weakness, the dizziness is from due to lack of oxygen because you don't have anything that really carries it. You'll have pale skin because the red blood cells is what kind of helps give the skin its color. You'll have cold hands and feet because the body's trying to shunt the blood and make it more efficient. You have shortness of breath because of the fact that you're not actually able to circulate enough oxygen. You have a fast heart rate because of the fact that the heart is trying to be as efficient as possible. The chest pain is probably because the heart is working so hard, and the headache is because of the fact that you're either shunting the blood or because of the fact that you don't have enough oxygen, and also the cognitive problems, same thing. So as far as blood work, they're going to look at the hemoglobin and hematocrit. They'll look at the reticulocyte count. They'll do the RBC indices, iron studies, vitamin B12, folate, and bone marrow aspiration. The bone marrow aspiration is more due to to find out if there truly is a production problem, as opposed to your anemia being due to the fact that you're either bleeding somewhere or the fact that you're not consuming enough vitamin-rich foods that will help with the production of the red blood cells. I was going to mention about the iron studies. So the red blood cell is what carries oxygen, but it's the iron itself that binds both two things together. So it actually is a carrier, but it's a carrier by way of attaching to the iron. So if you're low in iron, you can actually have a lot of oxygen flowing around, but it's just not binding to the red blood cell. So that's why they do the iron studies. So with anemia nursing assessment by system, we mentioned this before. So generally, you're probably going to be very weak because of the fact that you have a lack of the red blood cells flowing around, lack of oxygen, lack of nutrients floating around. With integumentary, you're going to be very pale. With respiratory, you're going to be shortness of breath. You're probably going to have rapid respirations, trying to get more oxygen and to compensate for the fact that you don't have the red blood cells to carry it. For cardiovascular, again, your heart's probably going to go up. Heart rate's going to go up just because it's trying to compensate. Gastrointestinal, they're actually going to look here due to the fact that a lot of bleeding comes from the GI tract. So they might actually look in this area first just to see if there's any sort of problems. And what they'll do is they'll do either an EGD, which is the scope going down the throat into the stomach to see if there's any bleeding, especially ulcers. They can also go up. The farthest they can go with an EGD is the upper small intestine. And then if they don't find anything, they'll do a colonoscopy where they'll go into the opposite direction and they can go all the way up to the small intestine. And again, they're looking for ulcers, tears, bleeding, trying to find a source of why you're anemic. For neurologic, again, you're going to have the confusion or the headaches and stuff. So once you actually start fixing the problem or find out where the problem is, then you can start fixing the assessment areas that are causing the problems. So for nursing interventions, you're going to manage the fatigue. You'll probably do a lot of interventions grouped together, so that way your patient can actually do everything at once, and then when they're done, they can actually rest. Or you can actually break things into smaller phases of doing things, so that way they can rest in between both things. Maintaining adequate nutrition, because again, a lot of times anemia is due to more diet than anything else. Maintain adequate perfusion. So again, you want to be able to slow the heart rate down and not allow it to have it work so hard. Maintain prescribed therapy. And monitor and manage heart failure. Because again, your heart can only beat for so long, so fast, until it gives out. The next disease process is polycythemia. This is an increased volume of red blood cells. Hematocrit level is above 55%. Secondary polycythemia is excess production of erythropoietin caused by reduced amount of oxygen. This could cause COPD, or is caused by COPD, cyanotic heart failure, and living with high altitudes. So polycythemia is due to the fact that you have too many red blood cells. This is either your kidneys aren't working correctly and they're producing too much erythropoietin and your body starts pumping out more red blood cells, or because of the fact that you have COPD, your body will actually compensate by producing more red blood cells so it carries more oxygen, and the more oxygen it carries, the more efficient you're able to breathe. Living at high altitudes, those who live in, let's say, Denver, where the altitude is very high and the air is very thin, your body will actually produce more red blood cells in order for it to carry whatever oxygen you can induce, and then it can actually circulate and make it more efficient. Thrombocytopenia is a low platelet level. Bleeding occurs when platelet count is lower than 5 or 50,000. Lower than 20,000, you will see petechiae. You also see nasal and gingival bleeding, excess menstrual bleeding. And anything that's lower than 5,000, you'll see spontaneous bleeding. So essentially, you do not have enough platelets, and because of this, the less you have, the more bleeding you're going to have. So with 50,000, again, you'll start to bleed and bruise. With lower than 20,000, you'll actually start to bleed in specific areas, or you'll actually see a lot more bruising. And then with 5,000, you literally just bleed from every orifice of your body. With hemophilia, it's an inherent bleeding disorder. There's type A, which is a factor 8 deficiency, and type B, there's a factor 9 deficiency. Replacement of the deficient factor. So what you'll do is you'll infuse a lot of plasma and platelets. Too many transfusions can lead to intolerance of antibodies. So what this really means is that hemophilia means that you do not have the clotting factor, whatever type that is, and in order to keep you from bleeding to death every day of your life, you'll receive several transfusions of plasma or even platelets, and because of that, you're actually going to start building up antibodies because you're starting to chemically change your own body based on receiving blood products, and we can't make blood products, they have to come from humans. So because of that buildup, a lot of people who have had blood transfusions or plasma or platelet transfusions throughout their entire life, by the time they hit that 30, 40, 50-year mark, they start developing problems as far as transfusions. So avoid agents that interfere with platelet aggregation. So these are the people who are not going to take Coumadin, aspirin, ibuprofen, and heparin, because obviously they don't have the clotting factor and there's no point of thinning their blood even more. So the next one is DIC, which is disseminated intravascular coagulation. This is caused by sepsis or trauma. It could be caused by cancer or shock, placentae, or toxins and allergic reactions. Tiny clots are formed, and then the body forms fibrin degradation products or anticoagulants, and then this actually causes bleeding. So basically, your body starts to form clots due to several diseases or disease processes, and at that point your body tries, based on homeostasis, will correct the issue, and at that point it causes too much and then you start bleeding. Labs that you're going to look for are PT and APT, and this is due to the fact that you want to see how thin or how thick your blood is. And then D-dimers, because when clots are formed, they actually release a chemical, and that chemical is a D-dimer. So if the elevated, then most likely you have a clot somewhere. What you're going to do is fix the primary problem before infusing. The best thing you probably do is precipitate or fresh frozen plasma. Now we're getting into the leukemias. This is leukocytes that should increase with infection, but do not decrease when the infection is gone. So your body is reacting to some sort of infection. It produces a lot of leukocytes, and then once the infection goes away, you just still continue producing them. This can be caused by genetics or viral. It can be acute or chronic. And then the diagnostic testing is going to be a CBC and a bone marrow biopsy. They want to do the CBC to find out how high you are, and then with the bone marrow biopsy, they're going to find out if it's more of a bone marrow problem as opposed to some other cause. With Hodgkin lymphoma is a tumor of the lymph nodes, enlargement of one or more lymph node on the side of the neck. It could be cervical, subclavicular, or mediastinal. Spreads to other organs. It's painless and firm, can cause pressure on the trachea, which will cause coughing and pulmonary effusion. Hepatic involvement will cause jaundice and bile duct obstruction. This will also cause splenomegaly. Skeletal involvement will be bone pain. You also have the herpes zoster, which is either chickenpox or cold sores. And with mild anemia, you'll find that leukocytes may be elevated or decreased and platelet count normal. The erythrocyte sedimentation rate and serum copper level is increased. So in a nutshell, Hodgkin lymphoma is really the lymph nodes themselves becoming very enlarged, and it's usually caused by tumors. To do diagnosis, the health history and assessment of B symptoms, palpable lymph nodes of the chin, spleen, and liver. You'll do a chest x-ray, CT scan, and a PET scan. You'll see a CBC, platelet count, sedimentation rate, and liver and renal function. And that's just to find out if the lymph nodes in those areas are truly infected, and if they're infected, to what degree, and if they're actually starting to cause problems on the other organs. Treatment is going to be chemo and radiation for 2 to 4 months. And then for nursing care, you're going to, either cure them, or you want to actually have them stop smoking and drinking. And that's because the drinking causes problems on the kidneys and the liver. And if those are already having problems, you don't want to cause any more. And then stop smoking because this is a vasoconstrictor, and that will cause the lymph nodes to constrict, which isn't doing any good either. So for chapter 15, I mentioned, I think it's a very good chapter to look for as far as nursing interventions and things you can actually do and rationales. Here specifically are the tables, but again, I would probably just read the whole chapter and really understand it. Management of cancer is to either find a cure, which is eradication of the disease, or control it, which is containment of cancer growth, or palliation, which is the relief of symptoms and improved quality of life. So either you cure it, you control it, or you call hospice. So as far as cancer and surgery, the idea is for you to remove the cancer itself. Primary treatment would be removing the entire tumor or debulking. You have prophylactic surgery, which is removing tissue that has the potential for cancer. So from what I understand, those who are of high probabilities of breast cancer could be an example of that. Palliative surgery is to relieve symptoms. If you have someone who has cancer of, let's say, the liver and the spleen, or even the gallbladder, you can actually, even though they're in hospice or palliative care, you can still remove things to make things a little bit better. And then you have also reconstructive surgery, such as breast cancer. They have radiation therapy. This is ionizing radiation. It's electromagnetic radiation, and it's particular radiation. So radiation dosage and administration, which either can be external or internal. We have chemotherapy. It's anti-neoplastic drugs used to destroy cancer cells by interfering with cellular functions. This can be used with radiation and surgery, and it can be used as a systemic treatment. It's very toxic, cause for damage to cells responsible for hair, skin, and bone loss. And it can also affect the GI, your blood, renal, cardiac, neuro, reproductive. Basically, to me, this is basically giving yourself, or patients who have cancer, it's basically giving them poison to literally kill off everything that it could possibly imagine and start over. So when you have cancer patients that are receiving chemo, you are looking at every single one of their blood works just to find out, what's up and what's down and what needs to be replaced. And again, it's just basically taking pointers and then trying to correct an issue. So for nursing management, you're going to assess fluid and electrolytes, you're going to assess cognitive status, risk for infection and bleeding. Again, you are killing off everything, so it could be their plasma, platelets, or red blood cells, or you're also killing off the body's natural ability to actually fight off infection. You're going to administer chemo, you're going to prevent nausea and vomiting, managing fatigue, protect caregivers. I mean, these people are receiving chemo, so what goes in comes out, and when it comes out, it could actually affect others who actually come in contact with it. So, those who use one bathroom, should not use the other. You double flush. You should definitely clean things out. When you go to a oncology floor, they tend to actually have bathrooms that are made more of stainless steel as opposed to porcelain and things that are very porous, because the radiation can still stick around for a while. Again, check out page 346 and 356 for planned nursing care. That's pretty much about it. So again, I tried to point out ones that I think were probably more important as far as disease processes. Definitely read the chapters, and definitely pay more attention to chapter 15 as far as nursing interventions, rationales, and evaluations. So if you have any questions, please bring them to class.